occipital condyles, C1, and the base of the skull. And so I'm going to do that on the other side, and then everything should be free to just fold the head anteriorly away from the vertebral column and save all of the structures that you've so carefully dissected up till this point. Now on both left and right sides we've opened up the atlanto-occipital joints with the chisel, and what that allows you to do is to flex the head relative to the vertebral column, and sometimes or usually you have to, here's the dens right here, and we've already cut the cruciate ligament, but you have to reach in and cut across the midline because there'll be some ligaments or tendinous structures of the deep neck muscles that have to be completely severed in this area. And since you've already done a nice job to protect the structures of the carotid triangle, etc., there's no danger of going too deep there. So you can see now this is really loose and coming off, and blunt dissection. I'll try to finish this off and show you kind of what the goal is and what you gain by doing it this way. I can feel a... Now what happens in the finished product, and this will be a little easier if we were to turn the cadaver over, but I just want to, if you're in the right plane, you will be having exposed the anterior visceral compartment of the neck, and the fascia that we're looking at here is the bucco-pharyngeal fascia that surrounded the visceral compartment. All of the structures of the carotid sheath have been protected and saved, and we're literally looking at the back of the pharynx in this area. Here's the base of the skull. And the head can then be completely folded down. You'll turn the cadaver over, and this will be a little bit more obvious and easier position. But when you do the dissection back here, you now have gained the access to do that, but you've not had to transect any of the great vessels and nerves that you dissected in the carotid sheath, so they're all preserved for your review. Okay, having separated the head and the anterior neck compartment from the vertebral column back here, this is you'll be able to fold the head and neck compartment back and forth to easily review, and yet still retain some continuity with the aortic arch and other structures of the superior mediastinum or thorax. And again, here would be the retropharyngeal space, and this communicates down inferiorly into the posterior mediastinum through this hole you see here. So what you're going to do when you first expose this is see a fair amount of fascia that's lying on the pharynx. This is the pharynx right here. But we've already removed most of the fascial pieces that overlie this area, the bucco-pharyngeal fascia, and this would be one of the boundaries of the retropharyngeal space. So for orientation, then we can see on both sides the sympathetic trunks, the cervical sympathetic trunks, which have the distinctive grayish dark large ganglion. Here it is on the other side, the cervical sympathetic trunk. You can see the carotid artery on both the right and left side. On the right side, the internal jugular vein has been removed. On the left side, it's right here. So the carotid sheath contents are exposed right here. A midline structure down the posterior side of the carotid sheath, of course, is the vagus nerve. One helpful tip for differentiating sympathetic trunk from vagus nerve once you've dissected, because they're both not in the carotid sheath, just the vagus nerve is, but once you've dissected all the fascia, then they'll lie as parallel elongated nerves. The sympathetic trunk will always be medial to the vagus, and it will have the characteristic superior cervical ganglion. And what we need you to do is begin to peel away, pick away the bucco-pharyngeal fascia, and what you'll start to identify will be some nerve fibers that are fairly delicate on both sides here that come in at an angle, descending inferiorly and medially over the muscles that comprise the constrictor muscles of the pharynx. And we'll identify those in a minute. But just to give you some examples of these stringy nerves that are comprising the pharyngeal plexus. And these nerves are derived from three sources: the vagus, the sympathetic trunk, and the ninth or glossopharyngeal nerve. Once you find some branches, simply trace them back to their origin to see whether they're coming from the sympathetic trunk or from the vagus or from the ninth cranial nerve. The innervation or destination of those nerve components is something you need to to also learn, primarily we want you to focus on the vagus and the glossopharyngeal. The sympathetics are just doing some vaso regulation of blood flow through the pharynx. Okay, if you also when you finish that and expose more of the pharyngeal constrictor muscles, on both sides you should be able to identify the stylopharyngeus muscle. The middle constrictor is just inferior to where the stylopharyngeus muscle sort of disappears, and the superior constrictor will be above that point of insinuation. And this particular specimen, the superior pharyngeal constrictor seems very degenerated, very thin, and maybe had a denervation problem. We're not sure. But use that landmark of stylopharyngeus to identify those two muscles. Then wrapping around the stylopharyngeus muscle will be the 9th cranial nerve, the glossopharyngeal nerve. And they're delicate branches that come off the glossopharyngeal to contribute to the pharyngeal plexus. The inferior constrictor muscle, we freed up its inferior border such that I'm now insinuating the probe or forceps here on this side to identify the inferior constrictor. Those are the 3 constrictor muscles and some of the nerves associated with the pharyngeal plexus. There are 2 other cranial nerves that would be worth re-identifying here at this point. We did the sympathetic trunk on both sides, we did the vagus nerve, but you can also identify the 12th cranial nerve and the 11th cranial nerve in this dissection. It's kind of a good way to review both of those nerves and further trace the course of those nerves as they exit the base of the skull. So what I'm doing over here is identifying the internal jugular vein, and I'm holding the sternocleidomastoid muscle, and look for the spinal accessory nerve, cranial nerve number 11, that descends obliquely, pierces the muscle, and then is obviously going to continue beyond to the trapezius. Also, you can identify, if you go between the carotid artery and its bifurcation and the internal jugular vein, you can identify the 12th cranial nerve. So this is a nerve that descends from the base of the skull very close to the vagus, but it will have a much shorter course as it turns laterally and then anteriorly around the external carotid artery. And you recall, although we're not showing it here, that it travels in that direction towards the tongue by wrapping around the origin of the occipital artery. The next step will be to incise the midline raphe of the pharynx to expose the inside of the pharynx. To examine the internal anatomy of the pharynx, we will need to make a scalpel incision down the midline of the back of the pharynx. There's actually a line of insertion of the right and left pairs of constrictor muscles called the pharyngeal raphe. You probably won't see that very clearly, but that's basically the target for where this incision will be. Let me do it right down the midline here. And then fold back, you completed your incision, fold back the layers of the pharyngeal wall, or the constrictor muscles, and depending upon the cause of death or timing of death, you may see some debris, as in this specimen, within the pharynx and openings communicating anteriorly. I'm going to clean that up for a second and then come back and go through identifying the anatomy of this region. Now we have the pharynx open posteriorly and have cleaned this out. All of this area right in here where I'm laying the probe is portions of the pharynx. And the openings of the pharynx are anteriorly. One opening anteriorly is up towards the base of the skull, so I'm putting the forceps into the opening into the nasal cavity. And if you look into the nasal cavity, you can actually see the nasal septum way back in there. Just the floor of the nasal cavity and the roof of the oral cavity would be comprised of what we see here is the soft palate, which I'm moving back and forth. And of course, going in this direction is going into the oral cavity. And this is literally the dorsum of the tongue that we see in this vicinity right here. You can make out the circumvallate papillae when you do this, sort of a V-shaped or chevron-shaped series of taste buds that will help you differentiate anterior 2/3 of the tongue from the posterior 1/3 of the tongue. Okay? So this is all oropharynx, part of the pharynx that communicates with the oral cavity. This region is all nasopharynx that communicates with the nasal cavity. Inferior most component of the pharynx is down here I'm tracing as the laryngopharynx, and it communicates inferiorly into the esophagus. The opening in the laryngopharynx that also communicates in an anterior direction is right here where the forceps are, and this is the inlet to the larynx. So this structure right here, which is movable, is the epiglottis. Descending down into this opening is going into the airway system, the trachea, and the lungs. So laryngopharynx, oropharynx, nasopharynx. I mentioned the soft palate up here with the as a border between the nasopharynx and the oropharynx. I didn't mention the uvula, which is the little pointed piece of the soft palate. Within the oropharynx, and if we bend down the epiglottis, and I hold the head up maybe a little bit better, you can see into some depressions that are pockets off the midline. And in the midline is a fairly prominent ridge. This ridge of tissue and mucous membrane goes from the epiglottis to the tongue, so it's